All right. Greetings, everyone. This is Eric Glazer, and you are listening to the live recording of the Bright Spots in Healthcare podcast produced by Shared Purpose Connect. Each episode, we bring leaders together like the ones you see in front of you today to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and various healthcare related organizations across the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared on our show can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Our topic today is closing gaps in care. We're going to talk about innovative approaches to reaching quality goals. We've got a boatload of information and content for you. We have an incredible panel that's going to share all kinds of stories and bright spots. We're going to bypass introductions, or at least formal biographies of all of our panelists to save some time. Sherry Keels is our producer is going to post in the chat a link to all of their bios. I encourage you to click on them and get a sense of all the great information and great experience you're going to benefit from this great group that you see in front of you today. And we're going to jump into it in just a moment. If you want to help co-moderate this session with me, there's a Q&A module there, and you're probably all experienced with Zoom by now. Please feel free to use that Q&A module to submit questions to us. Please do not use the chat to do that, as it's too kludgy for us to kind of manage. We definitely, you'll have a better chance of getting your question asked and answered if you use the Q&A module. Our sponsor for today's episode is Healthy.io. They are one of our great partners of the Bright Spots in Healthcare podcast. We're really excited to be working with them. They are an innovative healthcare company that use smartphone technology to make remote clinical testing possible and help close those gaps in care. I'll give you more details on Healthy.io later on in the show. If you want to check them out right now, go to their website, literally healthy.io. That's how you get there. All right, let's get started. And let's talk about how health plans, and a lot of our audience listening, and I know represent health plans and ACOs, how they're going to sort of manage some of the NCQA changes that are going to impact everyone in 2022 and 2023. And I'm going to bring in Julianne Eckert to start us off here. Julianne is the Director of Quality Improvement at Clover Health. Julianne, how is Clover planning on managing the NCQA changes and gaps in care and the new HEDIS measurements?
Thanks, Eric. Well, to get started, there's a couple changes that have kind of come out. Kidney health evaluation wasn't really a surprise for us, but what's hard about that I think a lot of plans will see is that in the old CDC kidney measure, ACE and ARBs were used to hit a lot of that numerator compliance. But now there's two urine tests that kind of have to be back and back. And so EMR triggerless and lab feeds are going to be really key on meeting that measure. Additionally, advanced care plan, that measure is going to be very hard compared to this care of older adults measure, because if a plan had an advanced care plan on file from about 12 years ago, it counts for the COA care of older adults measure, but it doesn't count for the advanced care plan new measure because a yearly touch is required. And I think it's time for us to start ramping up on that as a yearly touch. And I can definitely see this being a display and stars measure down the line. What really excites me, though, and I know my colleagues here at Clover, is the race and ethnicity stratifications. And NCQA has made some big moves this year in advancing health equity by adding race and ethnicity stratification to existing measures to understand known disparities for 5 HEDIS measures. And for our STARS plans out there, that's actually 3 that it applies to right now. And I think using the existing existing measures will help plans transition more easily, but I definitely see this as a future accreditation measure and probable stars measure down the line. And I think NCQA and CMS are going to be holding plans accountable for intervening on those disparities. And for us, while our mission is to improve every life, we particularly focus on serving seniors who've historically lacked access to affordable, high-quality health care. And approximately half of our members who self-report their race or ethnicity identify as people of color, which is significantly higher than a 34% industry average for Medicare Advantage. And 72% of our members have been diagnosed with at least 2 chronic diseases. And about 66% of those members live in communities that fall in the top 5 area deprivation index deciles. And so we know that the higher ADI score for a particular neighborhood, the more likely its residents are to require additional support to address those healthcare needs. A recent study published by JAMA Health Forum found that MA plans that achieved higher star rating measures have higher magnitudes and quality disparity within their enrolled populations compared to lower performing plans with larger populations of enrollees with low SES and historically marginalized racial and ethnic groups, according to emerging research. And recently, CMS upgraded Clover's PPO plan, which is our largest plan, to 3.5 stars on the Medicare ratings for the 2020 measurement year. Currently, over 90% of Clover's Medicare Advantage membership is served through that PPO plan. But, we are able to target, we're ready for this. We build this into our DNA on tackling racial and ethnic and health inequities. Our benefits tackle social determinants of health. And for example, one of our newest benefits available to Clover members is a stipend of up to $800 a year to purchase over-the-counter medications or groceries as they need. And it can also be used to cover delivery costs. Therefore, anyone who's homebound or struggles with mobility issues or lacks access to transportation doesn't have to worry about how they're going to obtain the items that they need. And talking about the JAMA article about plans with higher disparities, smaller plans with higher disparities do worse. We're pleased to see that NCQA is partnering with CMS's Office of Minority Health on strategies to deliver equitable care. They've been conducting a study and they informed us that we were identified as a plan with strong performance on a prototype of the Medicare Advantage Health Equity Summary Score, which is a combination of CAHPS and HEDIS measures. And we're really proud of that achievement because it really speaks to our commitment to ensuring high quality care for those that are really in need. Also, our Clover Assistant. Our Clover Assistant is going to help us with a lot of these NCQA changes. That's a free software that goes to our network of physicians, and it brings patient info and insights to them real time. It's a platform that delivers huge amounts of data and then uses machine learning, decision rules, and evidence-based guidelines to develop and deliver real-time insights directly to physicians and other providers at the point of care while the patient is in front of them. And the goal of that tool is to help every doctor, whether they're in an area with high ADI deciles or an urban, more affluent area, to be more effective and efficient in the way that they deliver care. And it also works on a technology feedback loop, so it becomes even more effective over time.
Did you, is that homegrown or did you use a firm or license a platform?
It is homegrown. Clover is a health insurance company, but we're also a clinical technology company. So 50% of us is dedicated just to the Clover Assistant platform development.
Wow. Okay. And it's almost like a dashboard for the physicians to get that information in real time, is what I'm hearing.
Exactly. And it takes all of those insights, and we're not trying to replace the physician decisioning because we feel like the data, the science, and the physician clinical judgment is an art and it needs to be married together. So we surface that, and then the physician can use those insights and use their own clinical judgment as to the best treatment plan for the member.
So you could lot you covered there. You started off with diagnostics and remote patient monitoring. We talked obviously overarching gaps in care, social determinants of health, disparities in equitable healthcare. And there's a lot of underlying topics you also brought up. So it's a great stage setting for the rest of the conversation. Incidentally, folks, I forgot to mention this. I'm going to be sending you out a feedback form for all of you attending live right now in about a half an hour. So check your inbox. It's going to be asking you for feedback on how we did today, but it's also going to be asking you on what other topics we should be covering, like the topics that Julianne just laid out for 2022 for future shows. We use it religiously. It's how we've grown the show over the last almost 8 years, is to take your feedback and convert it into actionable, real programming. So we look at each respondent, each survey that you fill out, each one of you, we look at all your answers. So please take the time to fill that out. I will be bothering you with follow-up emails if you don't, and I know you're already sick of getting emails from me. So please do take that survey. I'm gonna talk, when we're thinking about gaps in care and we're talking about innovation, I know our minds immediately go to digital, virtual, healthcare in the home, RPM, remote patient monitoring. So Paula, how should health plans and ACOs be thinking about new platforms and technology to close gaps in care, increase value, say for diabetes and chronic kidney disease? Take us through your thoughts there.
Sure. Great. Thanks, Eric. And it's great to be here. I'm going to start with the obvious.
Let me, by the way, I'm sorry, Paul. I didn't even introduce you. So Paula Leclerc is the general manager for the U.S. market for our friends at Healthy.io. She's a wealth of information, by the way. But I'm sorry, forgot to even mention who she's from. So go ahead.
That's fine. I know you put it in the chat, so I'm not worried about it. So I'm going to start with the obvious, which is we need to meet members where they are. So we should be deciding and building innovative technologies for them, and it fits into their life, and not the other way around. So at Healthy.io, we coined that delivering healthcare at the speed of life. And if you think about it, all of us, even on the panel, have different speeds of life, and we shouldn't need to consume healthcare the same way for all kinds of medical conditions. And some we do and some we don't. So during the peak of the pandemic, Fierce Health published that 45% of Medicare members had a telehealth visit. That's up significantly. And I think we need to capitalize on that. And we need to keep that going. We need to keep the shift moving to home care, to digital. However, here's the caveat. I think we need to be really mindful on product design. So we need to be designing solutions with the end user in mind, the journey, the UI, how the app works, if it's an app. I think we can't assume that the same experience is going to be for all the demographics. And we need to keep that in mind. We need to talk to our users. We have to survey and we have to learn. But I do think we need to move home and we need to move into the digital space. And with respect to diabetes, Eric, I'm going to piggyback a little bit off of what Julianne said. We too have our eye on the kidney health evaluation. And one thing that we know is that it's going to require a blood test and a urine test. So the blood test will check for kidney function. And the good news for plans is that about 80% or more members do that today. So I think when we have our A1C drawn, we have our lipids taken, we have our cholesterol done, we have our eGFR, which is the blood test side of that. The urine side, the UACR side, which is checking for kidney damage, data shows that only about 40% of members are doing that today. So when we think about innovation around new gaps in care and how do we put these programs together, we need to be mindful that, Julianne, you said it right, there are going to be this urine piece that's not being done today. So at Healthy.io, we have a solution that we're rolling out where members can take this test in their home at their speed of their life. So they don't need to go to a lab. They don't need to go to a doctor's office. They need to have a smartphone, but the good news is we know that 70% do now have a smartphone. We have an app that is designed with ages 16 to 81 in mind, and we have a 99.5% usability on that. So bringing care to the home that allows members to test at their speed of life will address that adherence, hopefully, for plans and get it much closer to the blood testing.
Great. For those of you who are joining live late, please put your questions into the Q&A module, and our producer Sherry Kales and I will be monitoring that. You can help me co-moderate, and I'll bring those questions to light as time permits. Nicole, I also think around, innovation is about new ideas or taking old ideas and using them in a different way. So how can we be innovating around benefit design to accelerate better value-based care for higher risk patients? And Nicole, by the way, is the Director of Population Health Strategy at Humana.
Hi, thanks, Eric. So I'm just going to do a little note that I'm going to come with a little bit of a different view than the others on the call, using the lens of how social determinants of health impact the ability for a member to achieve their best health.
Hey, Nicole, do you mind just speaking up a little bit for us?
Sure. Is this better? I
feel
like I'm yelling now.
No, you could yell. Go ahead.
Oh, perfect. This is fantastic. And so as Paula mentioned, the first is meeting the member where they are. So it could be a benefit design, and we'll talk about some of those in just a second. It could be a clinical or quality program as well. And so we have created a couple benefit designs to do exactly this, meet the member where they are. The first is our Healthy Food Card, which is offered to quite a few of our members across the board, which allows them monthly to use the funds that are loaded on this card to go buy food. We often say that we never want our members to have to choose between filling a prescription, going to the doctor, being able to pay that copay, or being able to put food in their pantry, and not just any food, healthy food. We know that eating healthy, eating fresh food is expensive. And so anything that we can do to help our member have this opportunity really important. For some of our chronically ill members, some of our plans actually have an allowance where our Humana care manager can address specific needs, which could include things such as transportation, meals, a medical copay, assistance, or even purchasing a window AC unit. And this is really important because I'm going to give you an example. Imagine someone in the Deep South, their AC broke. It's August. We know how hot, humid, awful that is. This member has asthma and has a lot of trouble managing their asthma. And so they've been going to the ER quite a bit with some complications. Through this allowance, we would be able to purchase a window AC unit for the member to really help them have that cool, safe place to be in those 105-degree heat indexes. And so we really do try to build benefits or integrate the information that we have, and I know that Eric, we're going to talk about that quite a bit later, integrate the information that we have with our care managers and other associates within Humana to really help them make informed decisions to assist our members in achieving their best health.
Great. So we're going to share some different examples and success stories. But before we go there, Jeslie, when we're launching new programs, I want folks to kind of be thinking about there's always challenges and potential reasons they may not be effective. And I think realizing those challenges is the first step in overcoming them. So Jeslie Jacob is Divisional Vice President for Provider Performance and Provider Analytics, Reporting and Connectivity at Blue Cross Blue Shield of Illinois. And so Jeslie, I'd love to talk about how do you go about recognizing the potential risks and preventing Blue Cross Blue Shield from managing and closing these gaps? How do you do that first?
Yeah, good morning, everybody. Thanks, Eric, for having all of us. Good question. I'm going to maybe channel a little bit of Drucker. Drucker said, right, you can't manage what you can't measure, right? I think that's a pretty important piece to keep in mind in the realm of what we're talking about here. We've got, and I think some of the folks already referenced to this, but we've got large data gaps and material data latency in the data that feeds our quality measurement. Most of it's reliant on claims data, which has got a built-in, 60 to 90 day delay there. Clinical data is just not used at scale, and we're talking about quality measurement. And so the implication to that is when we have incomplete or not current data feeding the measurements, we don't have a real good picture of where we are. And so our rates are impacted by it. the gaps that we surface up reflect that. When you take that list to a physician, they look at that list and go, this isn't what I see in front of me. The member outreach efforts get impacted. So I think the focusing on efforts to make sure that we're doing everything that we can to measure it as best as possible. I think it's, just sort of getting the basics right, but I think that has an important trickle effect in all of the rest of the steps that need to happen in terms of provider engagement, in terms of member engagement to effectively move the needle on this topic. And I'll just give you just a simple example. I say simple example, but we were thrilled by it. We, connected to one of our state immunization registries. Overnight, our immunization measure rates jumped by 30 to 40 percentage points. So think about the impact of that, right? So when you've got that kind of an increase in your measure rates, that means your information is that much better, which means the actionability of that information to physicians and to member outreach and care managers is that much better. So that's just one example of leveraging clinical data at scale. I think it's just going to become foundational to doing this, right? Julianne referenced a couple of the measures in the Reliance and lab data. We know a number of them that are already out there: A1C control, blood pressure control, the list goes on. And those are real clinical quality outcome indicating measures, not just process measures. And that's, I think, where this becomes an important topic that I think everybody has to address in effectively moving the needle on this.
Gotcha. That's great. So let's get into some success stories or case studies. And Julianne, I want to bring you back in and talk a little bit about Clover Health and how else are they closing gaps? What's a key component to your overall approach?
Yeah, thanks. I definitely echo what Nicole imparted earlier and meeting the member where they are at, as each member is different like a snowflake. So heavily screening at every touch point is really critical so that we can get the data we need to action on that member specific needs. But at the same time, there are foundational elements that we build from the inside out. For example, broad networks. We feel open networks are essential for any plan that has health equity as its goal, because they're more likely to allow patients to see the clinicians that they prefer or trust most. And they also help ensure that members can access care where it's convenient for them without having to pay hefty sums to consult an out-of-network provider. We believe that the ability to choose one's physician and the trust that comes from that helps improve those health outcomes, and particularly in our underserved populations that face tremendous barriers in healthcare access. Another cornerstone is affordability. In and out network cost sharing parity. Many of Clover's plans have $0 premiums and $0 copays for primary care visits, regardless of whether that PCP is in or out of network. We believe it encourages them to visit their PCPs often as they feel is necessary, enabling doctors to identify problems earlier and reduce suffering and helping patients avoid deferring care for financial reasons. We believe the more successful we are at reducing or eliminating any and all barriers of care, the more likely that the member's health will improve. Medication management, we keep drugs as low as possible. Chronic care drugs are free. The Clover Assistant also enables physicians to extend our prescription length for chronic medications to reduce the cost of patients must cover in any copays for non-chronic condition meds. Doctors have used Clover Assistant features 28,900 times as of mid-2021, making medications more affordable for more than 12,000 members and saving them an average of $150 a year. And also going local is key. Our localism with Walgreens, our relationship has also helped address underserved areas at its very core. The Walgreens pharmacy teams are embedded in these communities where our members have established and trusted relationships. And additionally, the physical proximity of Walgreens Health Corners to their homes speaks to the very spirit of what we're trying to achieve here. And that's a differentiated experience to deliver individualized clinical and non-clinical services. And we are making care easy and convenient. And most importantly, bringing the care to members versus the members having to chase the care by traveling across the town or county to their doctor's office to have a routine wellness check. We currently have 37 built custom locations throughout New Jersey, and we've addressed thousands of open care gaps with Walgreens, and members have really responded positively to this new collaboration.
I'm just looking, that's a lot there. I was taking notes. So you're broadening your networks, you're not charging extra charge for out of network, your chronic care drugs you're giving out for free, and you're partnering with Walgreens to get more focused on local.
Yeah. And I would say those are probably some of our high level. I think like many plans, we definitely have our playbook of all the different things we do, but those are definitely the foundations of how we address our membership, especially when so many of them have social determinants of health and health inequities.
And I don't know if I'm probably gonna put you a little bit on the spot here, but for those listening and thinking, okay, that sounds all great, I'd like to do that or up the ante at my organization. How do I sort of create the business case? Can you shed some light at all? Like, how do you guys look at that from an ROI standpoint at a high level? And I don't want to get too deep into it, but how do you rationalize the spend?
Rationalize the spend for like the benefit design, or
Yeah, the entire benefit design that you laid out, the free chronic care drugs, whatever investment into the partnership with Walgreens, the creating, letting them go out of network. I mean,
Yep.
these are all sort of potentially risky in the spirit of managed care, right? Risky cost drivers potentially.
Yeah, increasing access to care. Part of the hallmark of this is getting the patients to actually be able to go to the doctors instead of them delaying care or having difficulty. I've been in West Texas, where a patient has to go 2 hours away to get to a PCP, and by embedding localism into their communities, and physicians that are in that, it doesn't matter whether they're in network or out of network, because the cost share is the same, increases the likelihood that they're going to be getting care versus delaying care. And additionally, if they're taking care of themselves by being able to adhere to their medications, by using their benefits, then that's going to decrease our MLR overall, because we're not having that delayed catastrophic illness. For example, I've seen studies where colonoscopy screening last year decreased by 90%, during COVID. And I think all health plans are catching up to that with their healthcare gaps. Well, taking the barrier so that they don't have to do backflips to actually get a colorectal cancer screening helps increase that access to care and that optimizing health.
Does the open network, does that, and this is from an audience member, so does the open network, does that help translate to better network adequacy from a regulatory requirement?
It does, because obviously we do have in-network members. We have a large provider network because we want members to receive their care, and we want our physicians to use our Clover Assistant software, but also too, from a network adequacy, being able for a member to choose a doctor that they identify with and have those trusting relationships with, for whether they have the same cultural background and understand where they're coming from, and have that increased trust, helps our members be able to feel like they have choices in their care.
Final follow-up from the audience. You spawned a lot of interest here, Julianne, and then Nicole, you're on deck here. So, how are you leveraging Walgreens to close clinical care gaps, and are they seeing PCPs or NPs at Walgreens?
Yeah, we do have pharmacists in the pharmacy teams in Walgreens. Walgreens actually does have clinical staff there as well. Everything that Walgreens is doing in the health corners does follow standard clinical guidelines. A member is able to come in and either get their A1C checked or a fit kit, or and close those gaps in care. Also, too, I mean, you know, Walgreens has become kind of an extension and an ambassador of Clover. When I was on site with them in January, it was heartening to see that a Clover member came into that health corner at the time, and she had a whole pile of mail, you know, of mailings that she had received from Clover, and she sat down with that pharmacist, and the pharmacist went through everything and just helped you know, explain, you know, what that meant if she had any questions, because she had difficulty reading. So, you know, it's really helping bridge that, and it's located in the members' community. So these are places where they already have those trusted relationships.
Great. Okay, that was great. I may have some follow-ups later on, but I want to. I've promptly got us unprompted, and now we're off schedule thanks to me. So I want to move. I keep us moving here. Thanks, Julianne. So Nicole, how is Humana closing gaps? And I know you have this bold goal program that I can't wait to hear more about. What are the key components to that and Humana's overall approach?
So first, I would say I agree with Julianne.
And by the way, quick PSA, because I'm getting this from some of the audience. Make sure you're yelling.
All right. Sorry about that. I am yelling now. So we completely agree that healthcare is very local, which is why in 2014 through 2015, Humana made what we call a very bold statement, and created a team focused on the communities that we serve. We call that our bold goal. And right now, we do have a really strong focus in 19 of our communities. That doesn't mean we don't do work and meet others, but these are the communities that need help more than others. And so one of the reasons we created this focus is when you think about Maslow's hierarchy, at the very bottom level, the very base of those physiological needs is the access to food and shelter. And so when we help members address those base needs, we are enabling them to focus on their health needs, such as getting primary care, medication adherence. Like others, we have partnerships with Walgreens and other entities where we keep that healthcare very local. We have very strong provider networks and have been very intentional at helping or opening clinics in our most impoverished areas. And we look at a social health need as a clinical enabler. So what is stopping? Think about that Maslow's hierarchy. What is stopping the member from obtaining the care that they need? And in turn, in the long run, closing those gaps. So some of the ways we get to addressing those needs is we screen as many members as we can. And right now we're screening about half of our Medicare population for health-related social needs. When we find those needs, we are connecting these members with a human who can help them address those needs and in turn address their gaps in care. That could be by providing information to our physician partners. It could be by providing information to our care managers. It could be by providing information to our customer service reps. So when someone at Humana or someone contracted with Humana interacts with these members, they have the information needed to help address those basic needs. We also have a very strong partnership with several social health access referral platforms, which really help us address this. For example, everyone within Humana has access to a platform at a national level, which while they're talking to a member, they are able to make that referral to the resource, or they're able to look in our benefit design to understand what benefits are available to help the member access the care that they need. It could be transportation. It could be the healthy food card, like we mentioned. It could be the allowance. It could be a clinical program that is available to the member that's really going to help them get past the episode, the clinical episode they're having at the moment. So we feel very strong in our approach that it's really about addressing those base needs in order to be able to address the overall clinical needs.
Are you, how are you, and Julianne, you could jump in here too. Are you guys focused on also bringing healthcare back to the home? And are there programs you have in place or thinking about there? That's an audience question. So Nicole, why don't you go first, and Julianne, you could jump in.
Sure, we absolutely are, which is why we have purchased Kindred, quite frankly, and we have other partnerships with companies like Dispatch, where urgent care can be provided within the home. We believe very strongly that people should be able to stay in their home to access the care that they need. In addition, should be able to age in place. And so however we can provide those resources to allow those things to happen, we're going to. We also have another company that we're invested very heavily in, which is called Hill, which is primary care within the home. So yes, absolutely, we have a very strong home focus.
Julianne?
Yeah, and I agree with that. And also too, one thing that is a little bit different about us is we have Clover Home Care, and that's our home-based primary and collaborative care service that accounts for the neediest 20% of our members who are most vulnerable and at high risk for morbidity and mortality. And we designed that program to better identify and care for our most medically complex, frail, and homebound members in their home. And unlike many other such value-based programs, we have our Clover Home Care MDs closely collaborate with the patient's pre-existing PCPs to provide that extra layer of support in the home that improves the patient's well-being and health outcomes. And members that are enrolled in Clover Home Care have seen a 17% decrease in hospitalizations compared to a control group of members with similar health profiles, and their overall medical expenses fell by an average of $325 per member per month compared to the control. The other thing I just want to mention is I saw a comment in the chat about digital literacy, and we believe in the value of video-based telehealth and offer comprehensive wellness visits over video to our member. However, we found that a subset of our membership didn't have the technical capability to do video visits, like they didn't have a smartphone, a computer, or Wi-Fi connection. And to address this need, we created our Videos on Wheel program, where we identified the members unable to participate in the video visits and then brought them a video-enabled tablet to use for that comprehensive wellness visit with their PCP. And the reality is that the members without access to technology or connectivity tend to have greater social challenges and support. And we realize that offering this service helped improve access for our most vulnerable members. And some recent stats, as of May, we had more than 95% of our annual wellness visits were done on video. And we're currently completing about 500 video on wheel visits per month.
Sherry, maybe, I don't know if we have time, but if we could put like something around, value-based care at the home or something as one of the topics for 2022 to see if this group, when they get the survey, could vote on it. It seems like we should probably do an entire session or two on home-based care. It's a good segue because I told folks, those of you who are joining late, Healthy IO is sponsoring today's episode. They're a perfect fit for this topic because I just want to tell you a little bit more about them. They're bringing healthcare into the home. So they're the global leader in turning your smartphone camera into a clinical grade medical device for at-home urinalysis and digital wound management. I think it was Julianne that mentioned at the very beginning, top of the show, around the urine tests. And so this is a way to do a home urinalysis test that aids in the diagnosis of chronic kidney disease, urinary tract infections, and prenatal testing. And it serves using your smartphone. And right now, they're currently serving over 500,000 patients worldwide. So they've been featured on CNBC, Fast Company, the Financial Times, and they're now partnered with some of our country's leading health plans, but they're also partnered with National Health Services in the UK, and they're being able to drive this kind of widespread adoption of their tool because it's just really easy to use and the patients are very adherent to it. And there's just huge potential cost savings. And they're really the first technology or healthcare company to be able to convert a smartphone into a clinically graded medical device to enable home testing. So I encourage you to check them out at healthy.io. If you want to just pick Paula's brain, Paula, as I said at the onset, is the general manager of the U.S. business. You can request a meeting with her through the survey. I'm going to take the feedback form, and I'll make a personal introduction to you. So it's not like I'm just going to have her shoot you a blind email. I'll make the connection for you, and then you guys could just have a chat and learn a little bit more about home testing using the smartphone. So check them out. With that as a stage setter, Paula, I want to bring you into the conversation and talk about how an example maybe you could provide, a success story you could provide working with a health plan around closing gaps in care, maybe using your technology. And then I also have a follow-up question around federal funding from an audience member. So go ahead, Paula.
Sure. Great. Thanks, Eric. And thanks for the intro. You did a great job. I have nothing to add. You did a wonderful job talking about us. But I'm going to break this into two pieces because I'm going to talk about contracting with us and then a success story. So when you work with Healthy.io, we really do believe that reimbursement should be tied to a benefit for a member and a benefit for a health plan. So as way of an example, when we look at the UACR test that's coming up in the kidney health evaluation measure, there's tens of thousands of members in your plans that have not done the ACR test. So 40% have done it. That leaves another 60% who need to do it. And that's just the measure. The other side is anybody living with hypertension should also be tested every year. So while the measure doesn't cover the hypertensive members, they should be concerned to you because anybody with albumin in their urine has a much higher risk of a cardiovascular event. So we would work with the plan and receive a list of names to enroll in our program. So we'll use 50,000 for now. So when we get your list of names, we would take all of them. And when I talk about the program, we start right at the beginning and we work with health plans on co-branding. So we believe that all of the welcome letters, even the shipper box should have the logo of the health plan because they don't know Healthy.io and they're going to trust the health plan more. So the program starts right at the beginning with the health plan on what's the best way to engage your members. You know better than we do. You've done more programs with them. So how can we work together? So we'll start with the branding and the welcome letter. We also want to let your provider networks know. So we don't want to have any physician abrasion. We don't want to surprise any physician that this test is going to be done in the home. So we'll work on a campaign with you on how do we launch to your provider network. And we're still not being reimbursed at this point. We'll then ship kits to 50,000, 40,000, 100,000, whatever your member list is that needs to have this test done. And it's only at that point, once a member completes the test, that we'll get reimbursed. So if 100,000 kits went out and 70,000 were completed, even though we sent 100,000, even though we did all the marketing, even though we worked with all your providers, the reality is we got 70,000 to do the test and not 100,000. So your benefit for either closing that gap in care, identifying people at risk for CKD earlier, driving your scores for member satisfaction up, all of that was done for the 70,000. And that's what we believe we've added value to you. And therefore, that's what we believe that we would be reimbursed for.
Hey, Paula, you mentioned co-branding with the health plan. Do you ever co-brand with the providers?
So great question. We're new, so we haven't launched in our provider network yet, and we would love to. I think that we have to work with plans to figure out what the right provider network would be and what the size is. Sometimes we find that each provider doesn't have enough for us to make the box. And you can imagine inventory and trying to figure out how many boxes and how many different logos and how many different labels. It would depend on size, Eric, but we'd be open to it. But there would have to be some value, some size in the number there for us to do it. And you know, when we talk about results, we find in an untested population, 30 to 40% of members have albumin in the urine. So they do need some sort of follow-up. So whether beyond closing the gap, which is super important, it's really more important that we have found these members that need to get back into the healthcare system and they need to be brought into their PCP for further testing. And if they have CKD, hopefully we can slow the progression by getting them back in the system and get them the right care.
Right. I want to get into the details of how to execute programs. I'm going to bring back in Jeslie in a moment, but it strikes me when you're talking, Paula. So I'm going to two things. One is there's a question from the audience, and I don't know if you can answer it, about funding. So the question that came in earlier, and I was holding back on it. Are there funding programs available to get smartphones at no cost or minimal cost to the health plan into the home and into the patient's hands? Do you know anything about that?
I don't. I don't know. I know in the Medicaid population, we definitely had that, but I don't know if the question's specific to Medicare or demographic.
Got it. So okay. And the other thing, Sherry, I'm going to put you on the spot here. So there was a white paper that Healthy.io recently published, and it strikes me that we probably should share it with the group. So there's this, Healthy.io released this white paper on both the importance of early detection of CKD, but also the value of the estimated glomerular filtration rate, the EGFR that you've been referring to. Using the patient's smartphone and the impact of that from a clinical relevance and efficacy standpoint. It's about a 4 or 5 minute read. I was able to understand it. I'm happy to send it to everyone through a PDF format of it, so you don't need to register online or log in to get access to it. So Sherry, why don't you put up a poll, and anyone that says yes, I'll just simply email you an attachment or a link to it, and it'll just pop up, and you don't need to worry about logging in. It's worth a quick read based upon everything that we've been talking about, and I think Paula just set the stage for it. Actually, if you are listening to this via podcast, so you're not here live, if you go to sharedpurposeconnect.com, and we'll use the /value-based, sharedpurposeconnect.com/value-based. You fill out your information. I'll send you an email with the PDF as well if you're listening to it on the podcast. So here we go. Execution is the key to all this. We've heard some great success stories. We have about 15 minutes left. I want to get into execution and the processes that need to be in place, the data that needs to be in place to close gaps in care. So Jeslie, what's going on at Blue Cross Blue Shield of Illinois, and how are you guys looking at that around measurements, providers, and how are you leveraging data to actually execute on gaps in care, and what could the audience learn from you guys?
Yeah, thanks, Eric. I'll say a couple things to maybe just set the stage a little bit. So, we've got 17 million-ish members across 5 states. We've got 250,000 providers across 5 states. We all and I completely agree about the fact that healthcare is local. We want to meet the members where they are. We want to meet the providers where they are. We also want to keep the cost of healthcare down, right? I think we have an optimization problem here when we put all of these things in place. So the way we've thought about threading that needle is, let's find the interventions and the investments that can scale and impact at large, right? Because I think when the N of one way of delivering it just doesn't scale, right? So pockets of excellence, as welcome as they are, I think we need things that can scale to have an impact and still do it in a way that we can continue to manage the cost of care. So I think a few different things that we've done is, one is just to continue to make sure that we've got the right investments in place to have the data to do this well. So this is where I think, and I've seen our partners in Humana, we work quite closely, Nicole, with some of your colleagues there too. We partnered closely on the investments that we've made in Epic as an example, but that certainly wasn't the first. We've had a number of investments in direct connectivity to EMR systems. Like I've worked for a good 15 years on the provider side. Clinicians just don't want to leave their home workspace, right? So the ability to bring insights back into their workflow so that the 15 minutes that they have with their member, they are able to get all of the right information, everything from what are the gaps to what benefits does this member have, right? That's another key piece of information that the physician or the care team is just not aware of. Technology is at a point where we've got tremendous predictive power, especially when we assemble large data sets. I think Paula referenced the CKD disease progression. We've done predictive models that are able to flag a patient's CKD disease progression much before anything shows up in diagnosis back to us, right? So that information is powerful for us to mobilize our care management resources, the physicians on the ground, and then really to balance the need to be member-centric. They need to be physician-friendly, yet be able to do things at scale. So I think that's kind of the balance that I think we've tried to do. And I will say this, and maybe it is, my perspective, but I just feel like the change in healthcare is going to be one step at a time. Right? It's just not a magic bullet that we just press a button, everything changes. So I think to augment a good long-term vision, I think we need to have clear bite-sized pieces that we can execute one step at a time, because it's going to take time to drive the change across a number of these things, right? Different technologies are in different programs are at different levels of maturity. So having a clear long-term vision, having clear next steps that we can execute on, and then for each step being able to tell the value story and the impact to your stakeholders, I think is the way to keep this moving forward. The other big piece for us is alignment with physicians through value-based arrangement. I think a number of my partners here talk about it. Super important, right? I think if we go at the members with 1,800 different things and 1,400 different apps, they have a lot of other things in their day-to-day life. So the more we can streamline the care team around the member, there is already an existing care team there. Let's work through them as much as we can. Let's empower them with information, with resources, with financial incentives, with data, with insights, and then try to do things at scale. I think that's, to me, I cannot stress the importance of that enough. So that's just a few of my thoughts, but certainly we'll let my colleagues jump in there.
Yeah, let me see if I could summarize that, because you really laid out a blueprint for everyone, and I want to make sure I capture everything. And I might have missed some stuff here, but the first thing you said was you obviously got to capture data, but I think what you were insinuating is that data has to be actionable insights. So that was one thing I heard that you said. 2, you need to enable the providers. 3, you need to be patient, long-term vision. You mentioned understanding that this is going to take time, so bite-sized chunks was another one, and then making sure the providers are incentivized. Did I miss? I mean, I know I took a bunch of information and I'm trying to summarize it here for the group. Did I miss anything?
I think you definitely got the key themes there. I think the balancing the excitement towards pockets of excellence, balancing that with things can scale. And I think that's really, we have this, hey, this works great, gives us great outcomes in this geography for this measure. Well, that's great. But how do we scale these things? I think that balance, I think, is always important. And I think part of it is, is probably not a factor for all health plans, but we kind of have the scale thing that we have to balance. And I think every time when we have to drive change at scale, it presents us different set of problems that I think we sometimes have to work through. But
God, yeah, it's great. Nicole, what processes and data do you have in place to close gaps in care? And just a reminder to yell a bit.
So first, Jeslie is speaking to my heart. Quite frankly, everything he was saying, I would echo wholeheartedly. First and foremost.
All right, that's breaking news. Blue Cross Blue Shield and Humana. Blue Cross Blue Shield and Humana agree.
Actually, Eric, we talked to our colleagues at Humana quite a bit.
Yes. Well, and I think, one of the things, Eric, I will say is I think it's a big misconception that the health plans don't speak. We do. We collaborate. We speak. We do what's best for the members within the community. So there's your PSA for the day, quite frankly.
Awesome. Love it.
Data, just obtaining the data and really getting those screenings out there, really understanding, working with Epic and Athena Health. Those are the 2 we're partnered with as well, to really ingest that information, make really informed insights right back to the provider as we know it. Let's not make it hard. One of the other things that we have done is we're actually testing a SDOH value-based program right now with 5 physician groups across the country, because we know today there is not reimbursement to address social determinants of health, whether it's screening, whether it's coding, or whether it's connecting those members to resources so they can get those base needs covered so they can engage in care. And so we are testing a value-based model today to really understand what those right incentives are and the best way to engage. And we are using analytics as well to surface these insights for our physicians through what we call our Compass platform, which is a platform that our value-based providers have access to today.
Nicole, can you repeat that? Could you repeat that platform? I missed that.
Compass.
Compass.
It's a homegrown platform. We call it Compass, and it's for our physicians to use. And there's a module within this platform that shows which gaps a member has. It shows surfaces all the information from our predictive models from a social determinants of health perspective, surfaces our social risk index, and really allows the physician or the office staff, let's be honest, it's probably office staff who's looking at this information, to insert this information into the physician's workflow as we're working out all the kinks with the EHRs in order to surface this directly within the EHRs. So it's really key to integrate within the workflow. It's really key for us to have gathered the information in the right way so we can use NLP, natural language processing, so we can create predictive models, so we can use AI in order to generate those insights so we can surface them within the workflow. And that is from beginning to end of the member's journey, whether we're talking about closing a gap in care, whether we're talking about slowing disease progression, whether we're talking about closing a social health need.
We're 5 minutes off. We got some really good stuff coming up here in the last 5 minutes, folks. So I want in 5 minutes, so Paula's going to talk a little bit about some tips. To bring some of these programs to bear, you're going to have to bring in strategic partners and vendors. Paula's going to talk about 2 or 3 contracting tips real quick. And if we have time, I'm going to bring in Julianne to tell you about a really cool strategic program you could bring to your leadership to sort of revamp the thinking within your organization and make yourself look like a hero within your job. So let's see if we can cover that. Go ahead, Paula, real fast, as far as advice you could give around partnering with vendors and strategic partners. What are some things that you should be thinking about if you're a health plan?
You're lucky I'm from Boston because we just talk fast, but I think there's really four pillars. And I think the good news is there are great vendors out there for all of you. But I think the first one is, and I mentioned it before, avoid physician abrasion. So these are in no particular order, but find a vendor that wants to complement what's being done in the office and not compete with it. I think too often we want to remove care from the primary care. Number 2, we are looking, you should look for somebody that's innovative, but in a very conscious way about UI, UX, and we're willing to co-brand. We're humble. We know that the trusted brand is probably not us. So how do we co-brand and how do we drive engagement in multiple ways in omni-channel, but starts with co-branding. Number 3, I would say, look for somebody who has a proven way in an omni-channel. So not everybody is going to take a text or phone call. We'll do snail mail if we have to. So you definitely want to be looking for that group that has the right engagement strategy. And the 4th, because you phrased it this way, Eric, in one of our conversations, I will say, look for a partner who will put their money where their mouth is. So if we are not driving a benefit that's measurable, if we're not doing what vendors collectively, that may not be the right partner for you. So somebody who is going to structure the contract that shares your benefit and shares your risk all at the same time.
Great job.
Fast enough for you.
Julianne, take us home. There could be a whole show on this program, but let's help some of our audience members become heroes at their organization. Tell us a little bit about how to create an empathetic culture and what you guys have done at Clover to drive that.
Yeah, and this we really take to heart as we talk about being, we have to start on the inside in order to bring it outside and serve our members effectively. One initiative that we're extremely proud of is our reverse mentorship program. And it gives our entry level and mid-level employees the opportunity to mentor a member of the leadership team and ask questions and develop a close personal relationship with those leaders that they may not work with on a daily basis. On the flip side, it's great for the leadership team to meet with and hear the viewpoints and ideas from the frontline staff. And we believe this is how you really cultivate diversity and perspectives within your organization from the ground up and inside out. Really instituting a true program around diversity and inclusion that lets everyone know that they have a voice and that their voices are being heard. And the mentees, and I was one just in this last program, we learn about a specific topic of our choosing, such as supporting employees with disabilities, persons of color or different cultures, or understanding our own privilege. So it's been really successful in our organization, and we're really excited about it.
Great stuff. Listen, I just want to thank, first of all, everyone who's listening right now live. Thank you for taking the time. That's an hour of your time. I don't take it lightly that you spent it with us. Please subscribe to Bright Spots in Healthcare. It's a way to get every single episode downloaded onto your tablet or phone, wherever you consume podcasts, Apple, Spotify, Google Play, Stitcher, you name it. And to our panelists, thank you so much. You're all so busy. You all spent time with me preparing for this show, the hour that you just spent now. You did great. I'll ask you to hang on here as I say goodbye for a second. But thank you all so much. Thanks to Sherry Keels and the team behind us to make this all happen. Until next time, until next episode, which will be next week, next Thursday, join us. This has been your Bright Spots in Healthcare podcast. Take care, everyone.